Hello everyone and welcome. All of you that are joining us currently for this webinar today. We'll just leave a few minutes to let everybody in and get everybody settled. We'll start the webinar at 2 o'clock. Oh, sorry, 1 o'clock. We'll finish at 2. We're going to start at 1. We'll just leave it another minute while people are settling in. Okay, so it's 1 o'clock. I think we'll get started. Welcome everybody. Thank you for joining us today. You've joined us today for the first in a series of QCS Lunch and Learn sessions. So this is part 1 of a 6-session series, and these Lunch and Learns are all about understanding the new single assessment framework and looking at how we can help you moving forward understand what you need to do now to get ready and to implement these changes. So a little bit of housekeeping before we get started. The webinar will be recorded and the slides will be shared with you, so there's no need to worry about that. That will all come to you at the end of the webinar. Also, at the end of the webinar, there will be a Q&A session, a live Q&A session, so you'll be able to post your questions in the chat. Please do post your questions in the chat throughout the webinar as they come up, and we will get to as many of those at the end as we can. Thank you also, those of you that have already submitted questions. Lots of those came in preparation, so thank you. You should find a lot of those questions are answered during the course of this webinar, so we look forward to giving that information for you. As I said, do stick around towards the end. You'll have the opportunity at the end of this webinar to sign up for the next in the series and all 5 of the following sessions that will be Lunch and Learns in the new year. So stick around and sign up for those sessions. Now, without further ado, let's move on. Next slide, please. So my name is Lindsay Rees and I am a Head of Social Care Content Product at QCS, and my background is 17 years in adult social care before I joined QCS, working in nursing homes and being a senior leader in adult social care. I will let Ed introduce himself shortly. Next slide, please. QCS is the leading provider of quality compliance systems, policies and procedures. And if you're already customers of us already, then you'll know that we provide 24-hour access to policies online using a digital app, policies, procedures, and also compliance toolkits and other forms of guidance that can really help you with everything that you need to know, all informed by our team of experts. Next slide, please. So I'll hand you over to Ed now, and Ed can introduce himself so we can get started with today's Lunch and Learn.
Thanks, Lindsay, and thanks for introducing me. I trump you. I've got 35 years in social care, but I started off as a care assistant and fell into social care like a lot of people did, but realised I loved it, became a manager, but most of my career has been involved in regulation and inspection of care services and working with the regulators on how inspections are done and how practice could be improved for inspectors. I've also been a commissioner of services and I did work full-time for QCS as their Director of Care Quality up until 2018. But I left in 2018 to set up my own business, but still work with QCS quite closely and provide support and advice to them. I don't know what the weather's like where you are, but it's chucking it down here, and I can hear the rain against the window, so I hope it's not going to disturb you too much. And just as something else, I've got a bit of a cough, so I sound a little bit like Mariella Folstrup at the moment. And I've got a pint of water next to me, so I might have to stop periodically to have a drink if it's getting too bad. So I apologise for that in advance. But at least it's on Teams, so you're not going to catch anything. So that should be okay. So just before we get into why CQC are changing, I'm just going to outline what we're going to talk about today. So we're going to look at why things are changing, what's staying the same, what's changing, when is it all going to change, what the potential issues are with the changes, and what do you need to do now to prepare to ensure that you're up to date when these changes are happening. So just moving on to this first slide, why are CQC changing? Goes back a few years actually. They are developing on the 4 themes in their strategy, which are people and communities, smarter regulation, safety through learning, and accelerating improvement. So everything they're doing is looking at delivering on that strategy. And this single assessment framework is one way that they think they can meet a lot of those strategic objectives, particularly the smarter regulation and engaging with people and communities. They've also done a lot of learning from the pandemic, like we all did, and they had to work more remotely during that period, as we all did. We all discovered teams and events like what you're part of today. Prior to the pandemic, they were quite unusual. Now they're the norm, and CQC are going to be exploiting that and using technology and working more remotely with you to try and get evidence and support their regulatory functions. They want to simplify the process. They want to be less prescriptive in their approach and more flexible in their approach. They want to trust the provider more and give them the opportunity to evidence how well they're doing. They've said they want to simplify it, but throughout this presentation, we're going to be talking about issues that are going to be encountered and whether the process is actually simpler for people on the receiving end of CQC, or whether it's just been simplified for CQC. They want to be more responsive when things change. So they've described it as being nimble in their approach. They want to respond to risk and change ratings without site visits and not wait for a planned inspection to escalate concerns. They want to act when the iron is hot. They want to really get involved and address concerns when they're made to know about concerns. They want to focus people's experience of care, so they're going to be engaging a lot more, or they say they're going to be engaging a lot more with people that use care, getting their views and following up on what people's views are with providers. There's also, you'll have heard the phrase about integrated care systems, and CQC have got a responsibility to inspect local authorities to ensure they're meeting the remit of integrated care systems. So integrated care systems in 10 seconds is about looking at the care provision across a region, and care homes and social care are part of that process and involved in that in particular regions. So the CQC are looking for information and evidence across a geographical area to inform their view of what is needed in that geographical area within that integrated care system, and how the relationships are building in a holistic way rather than a silo-based way, just based on care homes or domiciliary care or GPs. And it's also been 8 years since they started inspecting under the 5 key questions. So it's unusual for things to stay the same for longer than 8 years. So that could be another reason why they're looking at changing. Next slide, please. So let's start off with the simples about what's staying. So on the face of it, it looks like a lot staying the same. You're still going to be inspected and rated under the 5 key questions. Those ratings are still going to be the same. So you're still going to be rated inadequate, requires improvement, good, or outstanding. The fundamental standards are staying, so the regulations that underpin what you have to do are the same. So by definition, there's not going to be a huge amount of change to the enforcement process and how breaches are identified and what the consequences for breaking the regulations are. So like I say, enforcement is going to be largely similar, but that might evolve over time. And registration of services is largely going to be the same. Next slide, please. So it's going to be more evolution than revolution. That's another phrase that CQC have used. So just moving on to what's changing. They're going to introduce the single assessment framework, and it's actually started for some services now. And the single assessment framework is what I was saying earlier on an earlier slide about looking at services in the same kind of way. So if you are a hospital, if you're a GP, if you're a domiciliary care, you're all going to be assessed under the same framework. So CQC are going to have the same binoculars looking at all different kinds of services. And I'll talk more about that later, and that should become clearer in some of the later slides when we talk about the single assessment framework and what's entailed. There's the development of the quality statements, and some of the questions that were sent through before this presentation were about CLOEs and quality statements, but we can definitely say the CLOEs are going. So the word CLOE won't be used. Key lines of inquiry are not going to be used in the future and are going to be fully replaced by the quality statements. And we'll talk more about them later. Underneath each quality statement, there are I statements that are statements from the user's perspective and what people using services expect to see and the quality of care they expect to receive. So the frequency of inspection is not going to be based on a rating as it is now. Like it used to be that if you were good, you could expect an inspection every 2 or 3 years. If you're inadequate, maybe every 6 months. If you're outstanding, you might not have had an inspection in over 3 years. But now that's been scrapped as a way of planning inspections. It's all going to be based upon the evidence that CQC are receiving and their analysis of you as and assessing the evidence and coming up with what their views are of the quality of your service, and that will determine what action they take with you and how they treat you going forward. So they've called it an always on process. So it's not an on off like an inspection used to be a bit of a light bulb moment going on. You had your inspection, then things would go quiet. Then there'd be another inspection with a PIR being delivered in between. But now it's going to be more continuous assessment rather than an exam. So there's going to be an always on process from CQC. Next slide, please. So another big change is evidence, the evidence that you're going to have to supply to CQC and what CQC are going to look at when assessing your service. So there are going to be 6 sources of evidence, and again, I'll be talking a bit about those later on. So it's about how they're going to categorize evidence in an attempt to make the evidence easier to judge, assess, score, and rate, whereas previously it was an inspector's view based upon the characteristics of ratings, but that's not going to be happening in the future. It's about the pieces of evidence are going to be scored. So there's going to be a wider range of evidence used. So CQC are going to have their binoculars out and going to be seeking information from a much wider range of people. They're going to be talking to Health Watch, the local authority, people that use services, staff at your service, and other stakeholders involved with your service, the GPs or other primary care, OTs, pharmacists. They will be asking them for their views of your service and using that to assist with coming to a judgment. There's the use of the provider portal, because it stands to reason that if CQC are asking you to provide more information, and this will be done electronically, they're going to have to develop a system to allow you to share that information easily. And what they're doing is developing a provider portal. It's in place now for some providers, but it's very limited in its scope of what you can do, and they're testing out and developing over time. And this is going to be central to provide you with the ability to share information electronically. If that's not in place, I can't see how the system will work as effectively and as efficiently as CQC would like. So they're going to be scoring evidence to inform decisions and ratings. So it's going to be more, in theory, more transparent, because every piece of evidence will be looked at and scored and rated. And again, there's going to be more remote assessment and less reliance on a site visit. So you're going to have less knocks on the door from CQC, especially if you're a good service. It's going to be a very remote process with CQC. Next slide, please. So what else is changing? The reports are going to be changing, and it's been a constant issue for CQC and for CSCI ever since they were established about who were the primary audience for reports. And quite often they fell between different stools and couldn't decide. But they decided now they're going to come very much down on the side of the general public and the users of services, and providing information for them rather being used as a surrogate consultancy service, so you can use the report to identify areas to improve. They're going to be much shorter, more focused, and provide high-level, clear information for people that want to find out more about your service and the quality of your service. Also on the website, there's going to be more public updates of the quality. So it will be regular updates, not just after an inspection. It's going to be a simplified, transparent process in CQC's eyes, but there will be challenges and complexities ahead, especially with the scoring of evidence and the scoring of quality statements and how that will work, and also with having no characteristics of ratings that guide what could be the quality of your service. The we statements I'll talk about in a while, the quality statements are all focused at good, but there's no other information there about what's tantamount to an inadequate service or an outstanding service. There's also the provider information return. It's unclear how this will develop in the future from CQC yet, but it's still in place. But they've made a commitment that they're not going to add to the regulatory burden of providers and not asking for the same information twice. So there's going to be a period of transition with the PIR, I would have thought, as they refine the questions asked and the process that you'll be asked to complete that PIR. So if you're submitting information through a provider portal, they won't want it again in the PIR. So it's just a question of watching out and keeping tuned into CQC and QCS for the latest information about PIRs. Next slide, please. What else is changing? Now, this is a huge thing. You've probably not had much reason to be concerned about. It's largely a bit like a swan. CQC is a bit like a swan going along a river. Like above the surface, everything seems a bit calm, but below the surface, they've done lots and lots of paddling to try and get systems aligned to make sure this single assessment framework works, because they've had to root and branch change how they're structured, because previously they were structured in what was called directorates. So it was under adult social care or primary care. That's all changed now, because linked in with the, remember I was saying about integrated care systems being regionally based and interested in what's happening in a region, that's the way CQC are structured now. So a central hub that will provide national support, and still in 4 regions, but within those 4 regions, there's going to be between 110 and 115 local operations teams that are organised by geographical area, not care sector. And within each of those teams, there's going to be between 9 and 12 members, and they'll include someone to oversee it all, an operations manager. There will be inspectors, assessors and coordinators, but all those inspectors, assessors and coordinators will be in theory quite generic and looking at all the services in that geographical area. So you might find the people that have direct you're supplying information to and that contact you might not have as much experience about social care, because they're working in small teams geographically rather than having a whole directorate and whole team based on adult social care. It's going to be a challenge, and I'm sure lots will come out in the wash, and there'll be lots of shakedown of these teams and how the relationships develop over time. Next slide, please. So the 6 sources of evidence that I was referring to earlier on, it's very high level, the evidence that they've said that they will be looking for, and not particularly prescriptive. It's down to you to provide that evidence to them. So the evidence that they've asked for, and there's a lot of duplication in the evidence that they've said on their website as well. So there's lots of information about people's care or clinical records, about the process for give feedback on care or whistleblowing. Those are things that they're themes that keep coming up under the sources of evidence, of bits of evidence that CQC want to see you provide. But under each sector, there is different evidence, and it's all going to be based under these 6 sources of evidence, and you can see them there. So they're looking at people's experience of care, feedback from staff and leaders, feedback from partners. So that's the GPs, that's the local authority. There's observation of care, which I'm not 100% sure how they're going to do that, if they're going to do less site visits, but that's one of the categories they're looking at. Processes and outcomes. And I must say I find it extremely shocking that for social care, there's no evidence source for outcomes listed under any of the quality statements. So again, it's beginning to look like social care is a bit of the poor partner of the NHS. And when I pushed CQC about this fact and outcomes, they said it was much more focused on NHS, the outcomes. So it's about the number of people that are admitted to hospital. It's about length of waiting times. It's other outcome statistics that NHS have a plethora of, rather than for social care. But again, I just find it beggars belief, really, because they've been talking about care providers being focused on outcomes for the last 12, 13 years and evidencing how outcomes have improved, but they are not including it as a source of evidence. And again, this is going to be something that will come out over time more information will have to be provided by CQC on how this is going to. Just one more thing about this evidence. I try and use, it's a bit of a recycling analogy. Now, bear with me on this. The days used to be when we used to put rubbish outside the front door, didn't it? And people would come and take it away, and it'd be their responsibility to put it in landfill, burn it, or whatever they did with it. Now, there's more responsibility on us to recycle. So we put glass in glass, we put paper in paper, we put landfill in landfill. And it's going to be a bit similar going forward with evidence supplied to CQC. The more that you can do a recycling of that evidence and split that evidence up to make their job easier when they analyse and collect that evidence, the better it will be. I'll talk a little bit more about that later on. But next slide, please. So the quality statements, and just to reiterate, these are going to be replacing the CLOEs. So CLOEs are gone, quality statements are there. They're also going to be known as we statements. They're called we statements because it's directed at the provider. So this is what the provider will do, and they're focused on good. So if you read a quality statement, it's pitched at good, and it's what the provider should be doing to meet good. There is similar content to the CLOEs, but again, there's an increased focus on looking at independence and those other things that you can see listed there. So a couple of things that are going to be brand new to you that you won't have seen before about environmental sustainability, and there's a lot more about the rights of staff and promoting healthier lives. And again, reading between the lines, this is more, some of those are more focused on the NHS because it's a single assessment framework. And if you dig down into environmental sustainability, there are whole departments within foundation trusts and big hospitals that are focused on environmental sustainability, whereas for us in social care and smallish care providers, you'll just need to be aware of your recycling and ensuring that the providers that you are sourcing materials from have got some kind of green credentials and can satisfy the sustainability criteria. There's no other explanation for guidance for providers about in these we statements, just on good, and it's a challenge because it's all across the same sectors. But within it, there's no revelations. An inspection is an inspection. CQC haven't pulled any other rabbits from the hat and asking you to provide evidence in something that you've not provided evidence before in the past, apart from perhaps, like I was saying, environmental sustainability. Next slide, please. So the I statements, like I was saying earlier on, they're underneath the we statements, and they are linked to each quality statement from the perspective of the person that used services. And CQC haven't developed these in isolation. They've developed these with organisations, and one in particular called Think Local Act Personal, who've provided a lot of support and advice to CQC on the development of this. They are there under the quality statements, and they're very useful for providers as well, because it helps you to understand what good experience of care looks like for people that use services. Next slide, please. And now I'm not going to go through this, but that's an example how it all fits together. And this is the quality statement involving people to manage risk. You can see the we statement in dark blue, so that's what you should be doing, and it's pitched as good. And then in purple underneath, there's the I statements, is what individuals expect you to do under that quality statement. And it's the same for a care home, GP, hospital. There's no difference in these we statements and I statements. Next slide, please. CQC are also in the process of developing priority statements, which are going to be focused quality statements, which will always be reviewed if they are going to change your rating or inspect you on a wider basis. You just need to keep an eye on QCS and CQC for the latest information on that. But the impact on providers is not yet known about that. Next slide, please. Now, scoring of evidence. We got asked some questions before doing this webinar about evidence and how it will be scored. There's 3 slides here. It is a bit complicated, and I'm just going to skim over the top of this. There will be more detail provided by QCS, and you will have these slides, and you can look at the CQC website for the more information. But basically, each evidence category will be scored. So each quality statement has a number of evidence categories under it, and that's been defined by CQC. So each evidence, the evidence you supply under each of those categories will be scored. So 4 is exceptional standard, 3 good, 2 some shortfalls, and 1 significant shortfalls. And then for each quality statement, categories will all be added up, aggregated, and a percentage score given for a quality statement will be given. Next slide, please. So then a percentage will be, they'll convert those scores back to a percentage, and then we'll go back to a score, and then the score for each quality statement under a key question will be added up and converted to a percentage, which gives outstanding, good, requires improvement, or inadequate. Next slide, please. So the scoring will allow CQC to be more nuanced in their view, whereas now you are requires improvement, good, or outstanding. With the fact that they've got scores there, you could be at a top end of good, nudging outstanding, or the bottom end of good, almost falling into requires improvement. And I think there's an expectation that on the CQC, on the website, in time, they will start to reflect that nuanced approach. And CQC have stated that scoring evidence will be more transparent, objective than the current judgment methods. But, you know, the jury's out on that one, really, because they've said they're not going to be publishing the scores for each evidence category. So if they're not publishing the scores and how things are being rated, it's a struggle to see how they're being ultimately as transparent as they can be. And when you're assessed on the new framework and you already have a rating, that will be transferred over into the quality statement, as long as there's a correlation between the existing Chloe and the quality statement. But where the quality statement has moved, where the Chloe's completely moved from a quality statement, they have mapped it across to reflect the score. So the score will travel with the area, whether it's a quality statement or a Chloe. That was 3 slides, a real quick run through. As you can see, it's quite complicated, and I hope you haven't left the webinar as a result of those 3 slides, but it was important that we shared what CQC's thinking of it about it is. But really, to be honest, you don't need to worry about that too much, because it's what CQC are doing behind the curtain as far as the assessment and the scoring is concerned. If you just focus on providing really good quality services and delivering evidence to support that, that should be reflected within the scoring and the evidence category and ultimately your rating. I'd very much like to move on to the next slide, please. So enforcement, what will it look like? Still the same regulations, limited change to process, but I can see trouble ahead with enforcement, because if enforcement is going to be done without a site visit, how is CQC going to triangulate that evidence that a breach has happened? And taking evidence from third parties, how's that going to be judged effectively? It may change in the future, but we are where we are with it. And there's also evidence that CQC are becoming stricter with ratings and more services rating inadequate than less outstanding. For example, very quickly, just bear with me, in the month before September, 1.6 services % were rated outstanding. This is of social care. 38.9 were rated good. 47, nearly 48% were rated requires improvement, and 11.5% were rated inadequate. But for all care homes published on the website, 4.2 outstanding, 77 good, 17 requires improvement, and 1.2 inadequate. So you can see that in the month before, 11.6 were rated inadequate, but in a generally 1.2 have been rated inadequate. And I know those figures might be skewed a bit because CQC are focusing on services that require more intensive inspection process, but it's a real indicator that the needle is shifting towards being a stricter regime. Next slide, please. So when are the changes happening? They started on the 21st of November for a very few, 14 early adopters in the south. For the rest of the south region, it started from the 5th of December, risk-informed basis. For London and South East, London and East from the 9th of January, North and Midlands from the 6th of February. But this is what CQC have published now, but there might be changes because they've said they're going to listen during this rollout period, and changes might be needed, might be required, and there might be more delays. Next slide, please. So the concerns with the new framework, very quickly, I was talking about the provider portal earlier on, so it's about how to share evidence. That's going to be a real concern. A lack of information, guidance and detail from CQC. All that they've done is on the website, but it's still very limited as far as beyond the bare bones of what they're going to be doing and looking at. They've said how they're going to assess, but there's not a lot of detail there. And they're always asking for feedback from providers about what they need. So it's a bit disconcerting. They're still asking for feedback on how things could be improved and what could be done, but they're rolling out a system. It's like going on a journey, but not knowing where your destination is with CQC at the moment. That's what it seems to be. There's also going to be some concerns about CQC's arm's length approach and analysis of evidence and how they're going to do that without having boots on the floor and knocking on doors and actually observing practice. And that leads on to rating changes without a site visit. Some challenges about how that's going to be done, but it could be beneficial for providers, and some providers might be able to exploit this concern, because one of the main concerns that providers is had that they've been rated requires improvement maybe 3 years ago, and CQC haven't revisited, and they are still stuck with the required improvement rating when they've clearly done a lot of improvement. So evidence might be able to be supplied that allows CQC to change your rating remotely, which might be beneficial. An issue about not organised by sector but by locality. I'm sure things will improve over time, but there are going to be some challenges of where inspectors will have the specific skills they need, and there's also a possibility that organised by locality, that health services might take over social care, and social care as is the one, might just have to ride on the wake of the NHS and health services. Next slide, please. Again, some of the concerns about not publishing the scoring of evidence. They've also said that professional judgment might override scores, which again is a bit of a furrowed brow for me, that they've gone through this process of saying they're going to be transparent with scoring, but then they've got themselves a get out of jail free card by saying, well, if an inspector finds something different from what the evidence, the scoring of the evidence says, we're going to go with that. So we'll have to wait and see how that pans out. I'm sure there will be challenges ahead made by providers against the CQC, and there'll be a shakeout of what happens, and hopefully things will become more transparent and clear in the future. We might have more delays based upon the feedback from early adopters, and making one size fits all might be a challenge going forward. Like I was saying, it tends to be the NHS that grabs the headlines and takes all the leads the processes rather than social care. Like we all know the experience of vaccinations, and now social care was used as a test bed for that. Then when NHS said no to it, it was rolled back and no one had to do it. So take from that what you will. Next slide, please. So what should you be doing now? What you need to really do is look at the evidence that you have and ask yourself, is it able to be shared, and is it electronic? Thinking about that recycling analogy that I referred to later on, really important that evidence that you've got isn't just in your head. It needs to be written down. It needs to be able to be shared electronically with CQC. Is it up to date? You need to make sure that it's up to date, that you're sending clear information. They won't be interested in receiving evidence that's 3 years out of date. Look at and get to know the 6 evidence categories. Make sure that it fits under one of those, and that information is directly related to a quality statement. Don't just use CQC as a dumping ground. Don't drown them. When you've got the opportunity, don't drown them with information, because they'll just end up putting their fingers in their ears and not looking at it. You need to make their job as simple as possible and as clear as possible. Look at the best evidence you have, share the best evidence you have. Make their job easy for them by allocating it and relating it to a quality statement. Make sure that it focuses on improvement and outcomes. And I know I said that the CQC haven't got outcomes down, but you need to keep hammering home that outcome approach and making sure that they know about it. Make sure that it reflects what's important to people using services, because they're going to be really focused in that. So use surveys, make sure you've got update, make sure you've evidence changes as a result of what people say. Next slide, please. So what you should be doing now is you need to focus on completing a full range of audits, and QCS has got the audit center now, and you can click on that QR code in the bottom corner and get full access to a trial for the audit center, but Lindsay might be able to add a bit more information about that when she comes back on to speak. Look at developing improvement plans. So you've got evidence that you've found issues, but this is what you're doing about addressing the issues raised. Do surveys, engage with people that use your service, and increase the scope of engagement that you have with people. Think like CQC thinks. Who are they going to be speaking to? You need to get evidence from them and speak to them, and find out what their views of your service are so you can improve. Leading on from that is treat all touch points with the service as if they were CQC. If someone comes through your door, treat them as if they were CQC. Show them the best of what you've got. Be polite to them. Don't fob them off. Engage with them. Show them the best information you have. Let them see the evidence. Make sure that they leave happy with what you're doing. And also with the full range of audits, just going back to that, it's really important that you do observation audits. So you've got the evidence, objective evidence of what you've seen of what's happening on the floor. So you can in effect be CQC's eyes and ears, and they, if you can put improvement plans with that, they will trust with what you're saying and take what you're saying as far as observation is concerned. So you can be their eyes and ears. Next slide, please. Embrace change, see it as an opportunity rather than a threat. Develop the support networks with other services in your sector and locality. Look at what's happening in your region, not just in care homes, and reach out to other services and make yourself aware of what the local authority are focusing on, what services they're commissioning and what their priorities are, seeing how you can help them deliver their wider priorities. That way you'll be helping the locality and have a better reflection through the integrated care systems. Keep up to date with CQC, sign up for newsletters, webinars and their Citizen Lab, and also keep up to date with QCS, because we're all over what CQC are doing as well. Next slide, please. And I think that's over to Lindsay now. Thank you very much for your time. I got through 40 minutes without coughing, so hurrah for me.
Thank you, Ed.
I'm sorry it went on a bit.
No problem, Ed. That was fascinating, absolutely fascinating from start to finish. And thank you very much. And do take a moment to compose yourself, have a big drink of water. We've got a number of questions that have come in, so please do stay on the line.
It is water, by the way. It is water. It's kind of pint glass, but it's water.
Excellent. We will talk through some questions. So thank you for your engagement and your comments. There's been comments and questions during the webinar. So I think one of the a nice easy one, well not easy, but very topical, emotive, shall we say, one to ease us in. What do we think, Ed? Do we think that there will be a more softer approach to the new assessments in the beginning, given that early adopters are perhaps having had their hands held throughout the assessment?
I would like to think so. And CQC have said that they will be doing this gradually and they'll be sharing information. But I still think they need to be seen to be and are keen to show that they're a regulator with teeth. If your care is poor, they will be all over you and they won't hold back on going down the enforcement line, as I evidenced with that slide that showed about how more services are being rated inadequate with CQC. And I think if you are flexible and work with them, there's a good chance that they will be flexible and appreciate the effort that you're making to improve. I don't know what your views are, Lindsay, but I wouldn't take it for granted they're going to have a softer approach and use that as a cover for poor practice.
I think it's really important to remember that the law, the regulations, everything underpinning this framework, nothing's changed. So they're all the same, and so the expectation of the care that you deliver hasn't changed at all. So you can feel confident that if you are confident that what you are doing now meets the regulations, then it will still be meeting the regulations. It's just that you need to think about how you're going to evidence it in a different way. And I think it would only be human of CQC to allow a period of grace, but not with the quality, around how you're presenting your evidence. So think about that when CQC ask you for evidence, frame that with, I've never done this before, So how I'm sharing my evidence, I'm worried about, but don't be under any doubt about the underlying quality elements. It's just about how you share it. Moving on to the next question, which is on a similar line. So in theory, if you're rated good, will it be harder now to improve that rating to get an outstanding? And I guess that's in the context of the digital conversation. And I think, well,
I'm not sure if you can get the evidence together that shows you're outstanding or exceptional in what you're doing, or you're being really, really innovative, and share that with CQC, I think there's a good chance of it being recognised, and they would change the rating. But it's a tricky one. It's a tricky one, and I think CQC might be a bit reticent without observing care and coming to visit you to upgrade you from good to outstanding. But if you've got the evidence there and they score that evidence and they rate that evidence, you could almost challenge them to say, why haven't you rated this as outstanding based upon this evidence?
Yeah, absolutely. And it puts the ball in your court as a provider to say, okay, well, I've given you this evidence, you haven't come to see me. You know, invite CQC to see you based on the evidence that you've shared, and don't be frightened to challenge and to invite them from that perspective. Site visits, as they might be called moving forward, are still part of the process. The difference is that they're no longer directly linked to ratings, but that doesn't mean they can't be a part of a rating change. I think it's important to hold CQC to account to that and make sure that they do use the full suite of things that are in their disposal, which includes site visits. A couple of questions here. I'm mindful of time as well. So will the evidence, do we know, and I think I know the answer to this, and I'm not sure that we do know, but do we know if the evidence will be looked at by different inspectors rather than one or two? So there's another question linked to this around the scoring, and to avoid subjectivity. How do we know as providers that it's not going to be one person looking at it, looking up the scores and coming up with a judgment?
In the slide I showed about the operational teams, there are layers to it. So the way that it's been described with assessors, inspectors and operational managers, I would think, again though, it's swans beneath the water paddling away. I'm not 100% sure, but I would have thought that it wouldn't be one person's view if ratings are going to have to be, if ratings are going to change. There'll have to be a review process of that, and the operational manager will have the oversight of that, and there will be discussions across the CQC team to see whether those changes are justified, and a double check of the scoring of the evidence as well.
Yeah, it would only feel that's the sensible and fair way to do things. But it is, like many of the things about this framework, it is something that we're discovering as we go along, and the information is a little sparse from CQC. So we do learn as we go along. Next question is connected with evidence categories and sort of focusing on the observational element of it and the feedback from people who use the services. So I'll quote this from the chat. It says, so we are at the mercy of opinions expressed by pharmacists, GPs, OTs, etc. That sounds like an opportunity to strike back at providers when we have had to push back to ensure that service users get what they are entitled to. There's a lot in that statement. Just unpicking it slightly. I think where this this caller is coming from is that you may have advocated on behalf of a service user in order to get them something that they need. It might be a referral or an appointment, but in doing so, you may have rubbed some feathers the wrong way, and there may be challenging relationships in the community. And so the at the mercy of is that CQC may only see one side of the story when it comes to feedback from people. I wondered if you had some thoughts on that, Ed.
I think it's a very reasonable point, and I think I made it during the presentation that one of the challenges is how CQC are going to triangulate evidence, because that's what it was always based on, was triangulation, not just trusting one person's view, but getting an opinion from someone else to triangulate it. So I think it's a reasonable point, and I would be a little bit concerned about that as well. But what you would need to do is ensure that you've got the evidence there to share with CQC as well, so they can see the other side of the coin. So there can be a more of an open, transparent discussion about it. I would hope that CQC just won't believe one person's view and take that as the truth, but would come back to you to counter that information and provide alternative evidence or more supportive evidence that what that original person was saying should be reviewed and mitigated slightly.
Yeah, and I think it's very easy for me to say, and I know how hard it is, having managed a number of services myself, that keeping those relationships as positive as possible and as open and as transparent as possible, and documenting as well everything, even what's not said, when visits don't happen, keeping that evidence together, so that when you get the evidence collected by CQC, as Ed says, you've then got already, yeah, I know that happened on that day, and here's actually what happened from my side of the situation, documented at the time. But keeping those great relationships with your visiting professionals, OTs, physios, even when it's difficult, getting everybody in a room and finding ways to resolve and agree to disagree. Easier said than done, I know, but it will be increasingly important under the new framework to make sure that you maintain those relationships.
It might also be relevant to say that CQC have got this integrated care systems remit. So they are going to be looking at things more holistically. So if that person is saying negative things about your service, but it can't be justified, they might be saying the same things about other services, and CQC might come to a view about the organisation that's saying the negative stuff about other services and fit it into the bigger integrated care systems remit that they've got. So there could be less chance for rogue disruptors being overly negative about other services.
Yeah,
Possible.
Agreed. I think, thank you, Ed, and thank you for all the questions so far. There are many more coming in, and we won't have time to look at all of them today, but please be reassured we will look at them all after the event, and we will look to answer them. I have got time for one more, which is kind of more of a comment than a question, but it is as follows. I understand that there would be digitalisation of social care, and I believe the local authority will be enforcing care providers to use a care system that will enable local authorities and CQC to access live data from care providers. How true is this? And if I just jump in first and say, maybe for context, so there is an aspirational goal set in place by the government that by March 2024, 80% of care quality commissioned services will have digital social care records. And so by that, we understand to mean care planning, so that service user data can be transferred between social care and health is the objective. But that's 80%, and it's an aim, and it's aspirational, and there's lots of support, we hope, to do that. But it's not something that I believe is mandated. I don't know if you've got any thoughts on that, Ed.
I just reiterate with what you're saying, and there is a drive towards digitalisation. There is funding available from the government and from other bodies to support digitalisation. It is a big drive, but I don't think it's mandatory yet.
Yeah, And I think it is really important, obviously, you know, in order to present your evidence in the context of everything that we've just been discussing, that digital records obviously help. It makes it a lot easier if you don't have to scan things and print things. But it's a journey, and a journey, digital implementation and digitalization, a subject for a whole new webinar. So on that note, I'm going to bring us to a close, and I will thank everybody for attending. Next slide, please, which is our final slide. So at the beginning, you heard me say that this is the first of our Lunch and Learns, and indeed it is. And the format for this one will be slightly different. This format for this one is different to the next one. So the next ones are shorter and they will be more live and more interactive, because we want to talk to you, we want to get your opinions, and we want to help you learn. So if you scan the code below on this slide, you can sign up for all 5 of the next Lunch and Learns, and there will be one on each key question. And for each key question, we will explore in more detail the sort of evidence you need to provide and how you need to think about presenting that evidence in terms of the we statements and the I statements that we've discussed. So I'll just leave this slide up as we're closing so that you can continue to scan. You will get a copy of these slides, a copy of the recording, of course, and so all of that will come to you after the webinar has ended. So please don't worry if you haven't managed to capture any of the information on the slides. Without further ado, then, Ed, thank you so much, and thank you for struggling on with your cough and your sore throat. You've been a hero today, so thank you. Great presentation. I hope you've enjoyed it, everybody, and I look forward to seeing you on January the 11th at the next Lunch and Learn, where we will be discussing SAFE. Take care and have a good day, everybody. Bye-bye.
Thank you.